When I first started, resectable pancreas cancer had a very strict definition. You had to have a tumor that wasn't really involving anything and that you could easily get it out. And surgeons are amazing what they are doing now. And so the bar of, or the margin of what can be resected has expanded and expanded. Vascular reconstructions are routine nowadays. Our frontline chemotherapies cause these tumors to pull back. And so when we go in to explore them, even though it looks like the tumor is around the blood vessel, that's all scar tissue. So it's technically now feasible. So I don't think we have a strict set of rules. We have guidelines, we have parameters, but ultimately we often end up going in and looking around to try and figure out if in fact our imaging correlates with what we see. Is it technically possible regardless of what the imaging shows? So, you know, there is no strict rule about who's going to the OR and who's not, particularly in the advent of new chemotherapy. Locally advanced pancreas cancer has been thought of as incurable, unresectable, but our new chemo regimens have changed some of that. We have newer studies which suggest that we do convert some of those folks to resectable. Well, that leaves us with the question of, well, what do we do about radiation? When I was young, a long time ago, the standard with a locally advanced patient was in fact to give radiation as the initial treatment. As our chemotherapies improved, it sort of took a sidebar, if you will, or side priority to chemotherapy. But that really raises the question of should we bring it back, particularly in a preoperative setting. We have new technologies too. We have the traditional radiation of a 5-week course with maybe some capecitabine in conjunction, but we also have these new stereotactic radiation, the so-called CyberKnife, which can deliver a very effective dose of radiation over the course of just a few days. My bias is that I think there is a role for some preoperative radiation in locally advanced pancreas cancers that respond to chemotherapy, just like the patient in our case. Initial response to chemo, preoperatively give some radiation to further improve our chances of resectability. I think that's an appropriate step. You're faced with a patient with locally advanced pancreas cancer, hoping you might be able to get the patient to surgery. You've got 2 basic recipes for chemotherapy today. You have FOLFIRINOX, and you have gem-Abraxane, gem-nab-paclitaxel. We have had somewhat of a bias that FOLFIRINOX is the better, more appropriate regimen. But we all know that some patients respond to FOLFIRINOX and some people respond to gem-nab-paclitaxel. And so when we're sitting there looking at the patient, we're guessing, pure and simple. And we know that the 3-drug cocktail is pretty spicy, and the 2-drug cocktail is pretty easy, relatively easy. We don't want to lose a window to cure patients, and so our bias has generally been to use a FOLFIRINOX regimen in this kind of patient, where we have such noble aspirations. But I think more and more we are seeing that the 2-drug cocktail can likewise convert patients to resectable.